The challenges for cancer patients and cancer doctors has been complicated by our successes. What do I mean by that? So now we know that we have I-Os in combination or with a TKI in first line, but not everybody benefits. And even the people that benefit, some of them progress. What do you do next? And the industry, cooperative groups, prospective clinical trials have not yet done a very good job of addressing that unmet medical need. Let's talk about where the data is. We know that the disease is driven by genetic abnormalities dominated by VHL. So clearly TKIs play a major role in this. In my own practice, it's basically a choice between cabozantinib and Inlyta. If it's I-O, I follow that by cabozantinib. If it's I-O TKI, because you've already had axitinib, cabozantinib would be the choice. Certainly Inlyta could be used post I-O. But the challenge is no prospective trials, no comparative data. We have an editorial coming out in JCO in a few weeks looking at brain metastases in kidney cancer. And we talk about some of the challenges with some of these unique populations, bone metastases, brain metastases. And I encourage everyone to start to think about the kinds of relapses, because it probably won't matter too much if it's just a lung relapse, but if it's new sites of disease, symptomatic bony disease, central nervous system disease that requires SRS or radiation therapy, there might be some TKI choices that are important. And lastly, the question then becomes, well, if you've had an I-O in the frontline setting, what about an I-O in the second line setting? And while the industry would like you to believe that you could follow I-Os with other I-Os, there's absolutely no data to support that. So while we think about, well, if they had IPI, if they had Nivo, or they had Pembro Axi, and then they progressed, would you think about Ipi-Nivo or using something like CTLA-4 blockade? And while that is of interest, still no data to support that. And I have to tell you, the cost of these approaches are not inconsequential, both for the payer as well as for the patient and their family. And we'd like to really build that support for data that says expending those resources are valuable because they lead to results that are beneficial. So I think in my own practice, I definitely go to a TKI. My TKI of choice is Cabo. I don't have any difficulty if a person uses Inlyta in that setting or axitinib, but I do think that those are really unanswered questions.